I have to say, I'm really, really pleased to be here because I've always heard that this is a wonderful meeting, the Croy of Africa, and I wish I had come here before, and I'm thankful for the organizers to bring WHO and to bring me here to the meeting today. So I was given a topic which I think follows nicely from the previous topic, which gives you a sense of where have we come in terms of setting up guidelines for a global public health approach, and how are we addressing the evidence that comes in, and then certainly addressing things like emerging resistance, hopefully. So I have no conflicts to disclose. So I'll be walking through what is the public health approach. Some of you may remember this because this was started ages ago, 10 to 15 years ago. How treatment optimization as a strategy helps us achieve the public health approach, and how has this impacted on the evolution of the WHO treatment guidelines that most countries in Africa now are implementing, and how this can be then used as a model for expanding into the world of hepatitis, because I know you also had conversations here over the last few days on hepatitis as well. So the public health approach really got its name in 2006 when the WHO, with Charlie Jilks and team, in the era of 3x5, put out a paper in Lancet that said, how are we going to get to 3x5? We only have 1.3 million people on treatment. It's high cost. We have lack of adequate number of doctors around the world. We have a lack of adequate labs available. And really what the focus there was on simplification and the declaration of the 4 S's. So when to start, what to substitute, what to switch to, how and when to stop, and task shifting and decentralization, service delivery approaches that should improve adherence and retention. And these standardized, simplified treatment protocols and decentralized service really enabled the scale up of treatment to both adults, children, and women living with HIV. This then, we revisited this at WHO. Now this is a busy slide. We have several busy slides in my presentation, so you can certainly look at them at your leisure afterwards. But here we then take a relook at the public health approach in 2016 and 2018, and we further have attempted to simplify by moving to treating all and not having eligibility criteria, moving to rapid ART initiation with the idea that this will reduce mortality. We know this from the START and Temprano studies, and reduce morbidity and reduce transmission, U equals U, so bringing it all together there. We have PMTCT for program. Rather than complicated regimens, we have one regimen for women and during pregnancy, and this has programmatic simplicity. What to start, we move from multiple regimens to one single first-line regimen. How to monitor, moving from many labs to using viral load as our major monitoring lab. And where we provide treatment, we really look to decentralize and move to the community and outside of the facilities. And also allowing and enabling doctors, nurses, midwives, and now lay providers and peers to help support refills and provide treatment. But the public health response isn't just about the simplification of medicines. It also included civil society, political commitment, funding certainly was made available, and many, many efforts from the donor communities and implementers, as well as innovations in using data to be able to relook and ensure higher quality as we move forward. So does this matter? When you started to take a look at this study here shows South African townships versus Switzerland, where there was multiple drug regimens used and multiple visits, very similar to other high-income countries where it's very individualized approach. And essentially, there were the same outcomes with a public health approach and an individual approach for both mortality and virological suppression and virological rebound. We also know that there are multiple ARVs out there. And if you wanted to, you could pick a myriad. But the public health approach has really tried to bring it down to the simplified, so that we have going from different regimens where you can combine all of those previous ARVs into one fixed dose combination that helps with better adherence, patient preference, and reduced risks of stockouts as we move forward, as we scale. And with that has come the reduced price. So what we can see from here is the first-line price of ARVs over time reduced to much lower levels as the treatment coverage increased. And this is something that can be replicated in other big public health problems like hepatitis B and like hepatitis C, where we want to achieve elimination, but you have to have a number of people being able to access the therapy at reduced costs. We know take-up of innovation doesn't happen very well in all public health interventions. And this slide just shows that the treatments for malaria were well taken up when they were introduced at 5 years. They were taken up very quickly. But look at hepatitis B birth dosing. It did not get taken up even though it has been available for more than 25 years. And what is the problem there that stops innovation from moving forward? And I think part of what we try to do at WHO and with many other partners is monitor what's happening in countries. And that may be able to put some extra pressure, but it also helps to show the world that we're looking and we want to see that our innovations are moving. So for example, we follow countries that are taking up Treat All. And this slide just shows progress from a year ago, well, 2 years ago to July 28 after the guidelines were put out. And what we can see is this is one of the most rapidly taken up recommendation that we have seen, likely then leading to reduction in mortality and reduction in morbidity. And we know that we can follow that through studies. And this study from the IDEA cohort shows that after the initiation of universal test and treat, or Treat All, within 3 months, many more people were enrolling in CHEP therapy. So there's ways to have research questions answer also, does this work and is the impact useful? And what we see with dolutegravir is the same. We're following this over time. We're starting to see the new regimen being taken up, either as TLD or dolutegravir by itself. But as you can see, this innovation is a little bit slower in terms of the take-up, and it will probably change over time as we move into the next few years. And with that, the prices have gone down. So I think this is all together that there's simplification, following the innovation, disseminating the information, ensuring the prices are brought to the lowest possible range, and then moving forward so that people have the best regimen available. So what happens at WHO or other organizations to make this happen? We have a treatment optimization piece of work where we look at simplification, looking for less toxic regimens, once daily dosing, fixed dose combinations, cost reductions, sequencing, and durability. So this happens with many, many meetings, many reports, and also report back to pharmacy and to pharma and generics so that they can take action on this. And for the longest time, we were working towards efficacy and simplification, but after the past year, with the issues of the signal of neural tube defects with dolutegravir, as many of you know about, our focus has become more and more around harmonization. How do we use our drugs safely in pregnant women, childbearing age women, children, those with TB, and those who have other drug-drug interactions. And as you can see from this slide, for many of our drugs that are the most important ones for our first line, we still don't have enough information in this group around harmonization, and that's the area of optimization that we want to move more quickly in the coming years. So what do? We put out lists, something called the CATO report or the PATO report, CATO Conference on Antiretroviral Drug Optimization. And this one will show in 2 years, what do we want to see, which drugs, what at 2 to 5 year, what are some of our medium-term priorities in terms of new drugs? And over the longer term, I think we'll see some of the areas that you were talking about yesterday in terms of BNABs, maturation inhibitors, and long-acting injectable formulations. So we want to have a vision of what's the next strategy for a public health approach. And we put that out for adults as well as for children. And what's happened over the last 5 years, we've seen that it's been fulfilling itself, and the pharma industry and generics are also responding to this with many other partners. One area where we've had difficulty is with children. This is a group that has high levels of drug resistance because of being exposed through the placenta and breastfeeding from their mother's ARVs. And they're failing and having lower viral load suppression at much higher rates than others. But in terms of the timing to get ARVs for kids, it's at least 5 to 9 years after the adults' regimens have approval with stringent regulatory authorities. And so what used to be a very large pool of drugs for children ends up being very small, and now we're really focusing on trying to ensure that we have dolutegravir for children at the lowest age bands, and those are reflected in our guidelines. And what we're doing with children is even trying to shrink this faster through an effort of trying to do this all in parallel as opposed serially, meaning trying to get the researcher, the stringent regulatory authorities to work faster together. So what is the role of treatment optimization? It's to help us update global treatment recommendations. It's to shape the research agenda. It's to inform the world and ministries of health what's on the EOI, the expression of interest, that's for pharma industry, the EML, the essential medical list, as well as supporting the acceleration in countries so that persons who want these new drugs can have access to them. So how do we then take what comes out of all of that work on optimization, public health approach, and put them into our guidelines? And I thought you already had a presentation on guidelines yesterday, but I'm told it wasn't a full presentation, so I'll touch on some of it. But just so you know, since 2013, WHO has been putting out consolidated treatment guidelines that brings together the service delivery, the drugs, and everything you might need to know into one document. We've updated it again in 2016. In between times, we've had some updates. Last year, we had a very small update, which was an interim guideline really around what to use in first, second line, and in PEP. And we're actually meeting in about 3 weeks time to update that interim again, to really talk about what's happening with dolutegravir. And you probably have seen this before, but over those guideline updates, we have gotten to the point where we start earlier, simpler treatment, less toxic, and we have better monitoring strategies. And what I can show you is from which speaks to the point that was brought up earlier, is we now see dolutegravir or integrase inhibitors found in many sections of our treatment algorithms. And I think that that's important because we're trying to harmonize and make this easier at a country level. So we made recommendations in first line that dolutegravir is recommended. It's a conditional recommendation as we wait for more information about the note of caution concerning the potential signal of neural tube defect. We brought raltegravir, another new regimen, into first line for children or infants, neonates. And I think you all have heard about the note of caution. I just wanted to bring this up again because we're revisiting that in June with more information that will come out from both the PAMO study and many other studies. And I think you're having some presentations that are happening here from ADVANCE and other trials that have been looking at that. And we do have in our guidelines a woman-centered approach, and we're trying to expand that into the next update for the update to that interim guideline. And if you haven't seen this table is quite busy, but it's in the guideline that came out, was first shared at IES in Amsterdam in July 2018, and also online in a text version, and I have some copies that I'll certainly leave out here in December of 2018. And this really outlines where we use dolutegravir, and we use it as a preferred first line. We address the issue that was brought up, which we do with women who are in areas where there's potential NNRTI resistance, and this is something that we debated. We didn't have a lot of information. Should a PI be used in first line? What are the pros and cons and risks and benefits of using a PI in first line? And we'll be readdressing that as we go back to our guideline in June. As well as we have an option of efavirenz being used, and in this option, we also make sure that the woman's choice and her desire for pregnancy and her willingness and desire to have offer of contraception is part of the dialogue and discussion about choosing a regimen at this time when we still have not clear information about the neural tube defect risk. And what we do have here is part of our guidelines is if there is a known pretreatment resistance for efavirenz or nevirapine, that we had ideally wanted that country to move towards dolutegravir as a first line. And I think many of the countries are starting to move that way as well. In our second line regimen, we can use dolutegravir. What we don't have, and you heard from the previous speaker, is we don't know what the right to NRTIs to use are. And we suggest that you do optimize. That means if somebody has used tenofovir and 3TC in the first line, to use AZT and 3TC in the second line, which is not easy. If they've used AZT and 3TC in the first line, to then use tenofovir 3TC in the second line. These are not optimal, and we know that this is difficult to implement everywhere. So there you go. We see that dolutegravir now has a role in each of the regimens, and we need to follow this over time and certainly be aware that we have to watch for resistance, particularly as people are using dolutegravir as it's a new regimen. Just to say, in this world of optimization, we also look at the studies that are coming out. And we know which studies are going to be available at which time to help us decide when is the right time to re-up, to reorganize our committee, and to look at the evidence to see if we need to update. And we certainly have many, many important studies, some presented here: IMPACT, Odyssey, Advance, NAMCEL, Dolphin, SAPAMO updates coming due now, and that's why we're meeting in 3 weeks to review our guidelines. For kids, it's even more challenging because we want to move away from the NNRTI regimens. We want to have dolutegravir as soon as possible, and we certainly want to have the most potent NRTI regimen. And just to say, with children, you may see over the next 2 years that we keep reducing the dose at which you can use dolutegravir, because as the studies become available, we're going to update our guidelines. That may be difficult for program managers. It may be difficult for you to explain to your constituency, but we will do this because this is all in an effort of getting more children access to the better drug. And again, with children, we can use it first, second, and third line. I wanted to spend just a few minutes on a new area of optimization that we're taking really seriously at WHO. And I think last year, it was actually a year ago today, when we first really heard about the signal of risk of possible neural tube defect with the use of dolutegravir in the periconception period. And we realized that our drug optimization work around pregnancy, breastfeeding women is suboptimal, let's say. We want to see drugs that rapidly reduce viral suppression. We want drugs that are well tolerated in pregnancy. We want them to have a high threshold for viral resistance for women. We want to have favorable drug-drug interactions, especially if women are going to be taking any kind of supplements during pregnancy and/or post-pregnancy contraceptions, and safe for mother and baby. And this, we know that there's not enough research in this area. So if you're looking for a research project, this is a great area to investigate. And we've asked drug companies, generics, to really accelerate their work in this area. Because just like with children, this is from the time that a drug becomes available for an adult male, it can take 6 years before it's available or regulated for pregnant women. So we know that women often can't access the regimens that others can. So if you take a look at the DHS guidelines, we know there are many drugs such containing cobicistat that we just cannot use in pregnancy, etravirine, T20, rilpivirine, but there's others that we have had in use, but yet there's been not enough studies in pregnancy. And some you know very well, TAF, bictegravir, doravirine, et cetera. And WHO can't bring those into guidelines until that research is done, because we're looking for harmonization across populations and across pregnancy TB status. There are a few studies that are going on right now, but in this busy table, what you see is a lot of red. No studies, no data for pregnancy. So we ask the global research community to start taking this seriously and thinking about it. And why? This is an update from the 24 countries that we are regularly in touch with about their guidelines about using dolutegravir in first line. And you can see that there are still some countries where it's unable to be used with women who have childbearing potential. Some are moving towards a full informed consent or an informed choice. But we have a whole series of countries in the middle that either are advising the use of contraception, are looking for long-acting contraception, which we know is very limited in many countries. And so this is something that we as a global community want to solve with you. I don't want to forget that we've applied this to advanced HIV disease. We had a discussion last night with some people about advanced HIV disease. We can also take those OI drugs and preventative drugs and put them into a single pill. For example, there's a single pill for INH, B6, and cotrimoxazole, but it's not being used. And so how do we get that information out? That's another innovation that takes time to disseminate. Service delivery innovation, I think, has been going very well with multi-month scripting, with differentiated models, but I think we can also take that a bit further. Lastly, in my last few minutes, I just wanted to speak about expanding this into hepatitis. And I know this is important, especially in West Africa, where we have quite a bit of hepatitis B. And how we are addressing that in a public health approach, I think we can use the same approaches. For hepatitis B, 257 million people living with hepatitis B, 4.5 million receiving treatment. And the treatment, as you know, is tenofovir. And if we look at cascades, we look at our HIV cascade, here we go, suppressed. So we're failing in terms of hepatitis B. And I showed you that slide before. We've had hepatitis B birth vaccine for 25 years that hasn't been taken up. That could stop a whole future group of children from becoming infected. So we need to press on for that. For hepatitis C, same situation. We have about 5 million people now being treated with the direct-acting antiretrovirals. Most of them are in 10 champion countries, but we have a huge number of people to be able to reach, to be able to actually control hepatitis C and look for elimination. So at WHO, we've taken the same approach with public health approach, simplification, standard algorithms for treating, looking for a single pill, a fixed dose combination to the extent possible across genotypes for hepatitis C, strengthening the linkages from testing to care, decentralization, task shifting, taking the hepatitis treatment out of the hepatology office and into the community, which it's not yet. And I think this is something that if you're here and you're working on work in hepatitis, think about HIV. Because we're following the uptake of guidelines, and as you can see, there's access to DAAs and for hepatitis C at low prices in Africa, but not in many of the parts of the world in Asia where we need them. And the prices vary greatly. So this is where activism that the HIV community has put into reducing prices can also be used in hepatitis. And what we saw those slides earlier in the lines of suppression or the reduction of the drug pricing, what we're seeing with the hepatitis C drug pricing is a little bit of a, not as a rapid decline. So what can we do and what kind of research or activism could you do to change that trajectory and reduce that line? So key messages from this long talk, and you can certainly look at the slides for the greater detail, and I'll put out the guidelines later today. But the public health approach and optimization of ARV drugs in the last decade has really streamlined our global effort around HIV and has improved outcomes. We're sure of that. We know that we've been able to really reduce the number of drug classes and bring in new drug classes globally. We have new innovations. The point of care is the EID, viral load, crypto, and urine lam. WHO right now is making a decision about how to use urine lam, and those guidelines will be coming out in a month or two. And we've moved from eligibility to treat all, and from when to start to just rapid ART initiation. I think the next phase is how are we going to deliver this well? How are we going to engage and keep persons who want to keep taking treatment on treatment, improve retention, and we think the differentiated models of service delivery are part of that solution. So the next public health horizon, we want to improve this optimization for children, for women who are pregnant and breastfeeding, and we need greater trials, and we need to speed up that R&D time, and we need to take these lessons and apply them all over again to hepatitis, and I might add STI as well as we move forward. So I want to thank the organizers. Just to let you know, we're meeting, and I mentioned this before, and certainly, if you have any questions, I'm happy to take them. Thank you.